हेलो, तस्लीम ऑनलाइन ऑनलाइन दिया है। पढ़ो बताओ। पूरे पाकिस्तान नहीं नहीं ऑफिशियल साथ अभी अभी जी साहब। हेलो
जी अस्सलाम वालेकुम।
जी अच्छा। और मैं
जी
तहसीन
सर।
साहब को फोन तहसीन को भी फोन किया, मेरे ख्याल वो भूल गए थे, कहते मैं अभी ऑनलाइन आ रहा हूँ।
ठीक है, बकर साहब से भी मेरी बात हुई फोन पे, फिर वो कह रहे
अच्छा
कनेक्टिविटी का इशू है, मैं शिफ्ट होके अभी जबरदस्त ज्वाइन कर रहा हूँ।
अच्छा, फिर क्या करें, कुछ लोग जो ज्वाइन कर चुके हैं वो वेट कर रहे हैं।
साइड बाय योर साइड। मेरे ख्याल में अगर कहते हैं तो हम इंट्रोडक्शन शुरू करते हैं सर।
मेरे ख्याल शुरू कर देना चाहिए, मगर सब ज्वाइन कर लेंगे। ठीक है
ठीक है सर,
जी।
प्लीज सर।
जी और अभी ऑनलाइन है, सुन रहे हैं सारे मेरी बात,
जी सर, सुन रहे हैं, बिल्कुल सर,
जिन्होंने ज्वाइन किया हुआ।
बिल्कुल सर।
अस्सलाम वालेकुम जी। On behalf of Pakistan Orthopedic Association and the editorial board of General Pakistan Orthopedic Association, Dr. Zaula Bajwa, editor-in-chief, welcome you for the first journal of the club of JPOA online. You are most welcome to join us. And to start with, I request Mr. Saad to start with a recitation from the Holy Quran, please. Mr. Saad, please.
यस सर।
Please.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. لله ما في السماوات وما في الأرض وإن تبدوا ما في أنفسكم أو تخفوه يحاسبكم به الله فيغفر لمن يشاء ويعذب من يشاء والله على كل شيء قدير. آمن الرسول بما أنزل إليه من ربه والمؤمنون كل آمن بالله وملائكته وكتبه ورسله لا نفرق بين أحد من رسله وقالوا سمعنا وأطعنا غفرانك ربنا وإليك المصير. لا يكلف الله نفسا إلا وسعها لها ما كسبت وعليها ما اكتسبت. ربنا لا تؤاخذنا إن نسينا أو أخطأنا ربنا ولا تحمل علينا إصرا كما حملته على الذين من قبلنا ربنا ولا تحملنا ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين أنت مولانا فانصرنا على القوم الكافرين أنت مولانا فانصرنا على القوم الكافرين.
Jazakallah. Sir, over to you.
Thank you, Ji. Bismillah ar-Rahman ar-Rahim. First of all, a brief the introduction of the presenter, Dr. Israr Ahmed. He is Associate Professor at Hayatabad Medical Complex, Peshawar, and he is an elected Treasurer of Pakistan Orthopedic Association. And he will present his published article, which already it was published in the Journal of Pakistan Orthopedic Association, JPOA. He will present his article, and after that, there will be a section of questions and answers, and the remarks by the expert panel. Today, the expert panel is Professor Abu Bakr Siddiq. I think he doesn't need any introduction. He is one of the senior most accomplished surgeons of Pakistan and a past president of Pakistan Orthopedic Association. So we have requested him to be the today's guest, as well, guest of honor, as well as the panel expert. He will give his remarks, and finally we'll conclude the session. So I request Dr. Israr Ahmed to start his presentation, please. Over to Dr. Israr Ahmed, please. Hello.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank Professor Ziaullah Bajwa Sahab, the Editor-in-Chief General of Pakistan Orthopedic Association, and are the editorial board of JPOA for giving me this opportunity to speak in this journal club. So thank you very much. And now I will start my formal presentation. The clear as आवाज?
Absolutely clear. बिल्कुल clear.
Yes, I am Dr. Israr Ahmed. I work as Associate Professor at the Department of Orthopedic and Spine Surgery, Hyderabad Medical Complex, Peshawar. And I am also the supervisor of our Arthroplasty Fellowship Program of Pakistan Orthopedic Association. So today I have been given an opportunity to present our published article, which was published in the last issue of Journal of Pakistan Orthopedic Association. This was actually on the accuracy of pre-operative templating of total hip arthroplasty. And here you can see the citation of the article and all the co-authors listed. So you all know that pre-operative planning is important for any successful total hip arthroplasty. And pre-operative templating on radiographs is considered essential part of planning to avoid post-operative guesswork and surprises during surgery. It is said that a goal without a plan is just a wish. If you want to reach a goal, you need proper planning for that. Otherwise, it will not be possible to reach that goal. So this is very true about preoperative planning in total hip arthroplasty or total knee arthroplasty. Now, what are the goals of preoperative planning? We want to shorten our learning curve for any new implant system by exercising this preoperative planning and templating. We need to predetermine the prosthetic size, the type of the implant, and the positioning of the implant. and we would like to equalize the limb lengths as well. And the proper femoral offset needs to also be equalized. And we can identify by proper planning any need for any special equipments and special implants, like very large sizes, very small sizes. And unless we do proper planning, we can't do that. And if we are unable to do that, this can lead to embarrassment in OR. It is said that each procedure should be performed 3 times by any surgeon. First time, when you see the patient and he has come with for initial consultation, you start thinking of your surgery at that time. And the second time is when you do meticulous planning with all details. And this part of the planning includes pre-operative templating as well. And you do the third time the surgery while actually you are in the operation room. So you need to repeat this. Once you encounter the patient, then you start thinking about your surgery, you start planning, and then if you do proper planning, then you can perform the surgery well in your OR. Now coming to the actual topic, which is preoperative templating in total hip arthroplasty. What is a templating? A templating is actually a trial of implants on radiographs. Before you go to the operation theater, you take the radiographs and you exercise your surgery on these radiographs. This is called preoperative templating. Now about our center was recognized by POA in 2017. For this recognition of our center, we started to develop a comprehensive protocol for our trainees and our fellows, which included preoperative planning. And since then, preoperative templating for both total hip arthroplasty and total knee arthroplasty is routinely done in Hyderabad Medical Complex. Our residents and our fellows routinely do preoperative templating. In this particular article, we have studied the accuracy of templating regarding the size of the implants only. There are other factors which we can do, we can study with the templating, like the positioning of the implants, like the limb length discrepancy, etc. But in this particular article, we have focused on only the sizes of the components. The objective of this article was to determine the accuracy of templating total hip arthroplasty implants when compared with the actual intraoperative size used. So we did templating on the preoperative radiographs, and then we compared this size which we had calculated on the template with the actual size we used in the operation theater. This was done in the Department of Orthopedic and Spine Surgery at Hyderabad Medical Complex, and it was done from 2020 January to 2021 January. This was basically a cross-sectional and observational study. We included all adult patients who are both gender who underwent total hip arthroplasty. Hospital ethical committee approval was taken, and patients' detailed history and physical examination and findings were noted. There were total 60 patients who were included in this study, and preoperative templating of all these patients were done on digital AP X-rays of the pelvis for cup positions, sizes of the implants, both the cup and the femoral implants, the femoral offsets, the neck length and limb length discrepancy. And cemented total hip arthroplasty was done in these cases. We did not include uncemented cases. This study only focuses on cemented arthroplasties. And the actual sizes of the implants were noted during the surgery, and we compared these sizes with the size which was on the templates. The inclusion criteria include all the patients with osteoarthritis, with neck of femur fractures, with avian and failed previous osteosynthesis. Neck of femur fractures fixed with DHS or screws. And we excluded patients with pathological fractures and revision surgeries. What we did proper epi-pelvis views, including both hip joints. The upper half of the femur with 15 degree of internal rotation. The patient's limbs were internally rotated 15 degree, And the film, the radiology department focused, made it 110-degree magnification with about 36 inches, 1.2 meters distance. When the film is taken, it's 110% magnification. But nowadays, they actually calculate it with the help of ape after doing digital X-rays. So the magnification factor was 110%. This is how the X-ray is taken, internally rotated, both limbs, and epipelvis X-rays. And then a single surgeon, the fellow or the trainee who is trained in the arthroplasty, calculated the stem and acetabular sizes on the X-rays. We used Zimmer and United systems. Sometimes we use Zimmer and other times we use United U2 system. And the preoperative implant sizes were noted and that compared with the peroperative findings. These are the actual templates. We do evaluate the quality. We do a good quality radiograph. And then we, as I said, we determine the magnification and then we draw lines like teardrop line between two lesser trochanters, and then we draw a line to calculate the actual inclination of the cup. Component, we see the accurate cup position, the cup version, and cup tilt, abduction angle we call. And for this, there are important landmarks on the X-rays, like the teardrop. The inferior part of the cup should touch the teardrop, but it should not cross medially to the collar line, and it should flush with the superior rim of the acetabulum, and also the interior posterior rims of the acetabulum. Of course, there are certain soft tissue landmarks also which we consider besides these bony landmarks. Now, this is the cup position we keep. It should contact the lateral wall of the tear, and it should also have contact with the dome here. This angle, this abduction angle, or the inclination should be 45 degree, between 40 to 60 degree, and ideally it should be 45 degree. This should make an angle with the inter-teardrop line. This is how we do it on X-rays. This is the teardrop, and our cup should rest here. It should not cross medially to the collar line. And here, it should not rest on the osteophytes, rather at the lateral edge of the acetabulum. And this angle should make about 45 degree. Now, operatively, there are certain important landmarks which we considered. This is the acetabular fossa. Here, it is a unicortical plate, and your cup on this plate. Here is the transverse acetabular ligament, which is an important landmark inferiorly for the cup. When your cup touches this transverse ligament, it means you are on X-ray, you are at the teardrop line. And inferior edge of the cup extends to the top of the obturator foramen, and lateral edge of the cup should flush with the acetabular edge. And this is the transverse acetabular ligament, which is a very important landmark during surgery. This is the position of a cup. You can see that this is the transverse acetabular ligament. This edge of the cup just touches, or sometimes this transverse acetabulum can overlap over the cup, and then it is positioned at this proper place, and superiorly it is rest at the edge of the acetabulum. And similarly, the size of the femoral component, the neck cut, and the offset is calculated. We actually put the implants over the X-rays and see the sizes. There are various systems. As we said, we use the Zimmer system or the U2 system. But there should be adequate cement mantle. 2 millimeter cement mantle is considered adequate. Now, about the results, this was basically very short. We only focused on the sizes of the implants. So there were 60 patients, and 22 were females and 38 were male. The age ranged from 40 to 70 with mean age of about 62 years. Now the matching of the stem size with that in the template. Our sizes accurately matched the size we calculated on the template in about 70% of cases. And when we take about a difference of plus minus one size higher or one size lower, then the accuracy raises to about 90%. And only in 8% of cases, there was gross variation in size calculated on the template and the actual size used. So we can say that in about 90% of cases, preoperative templating actually matched the size with plus minus one error. Similar was the case with the cup size matching. It accurately matched in about 70% cases and with a difference of plus minus one in about 15% cases. So both the cup and the femoral stem matched with our preoperative completed size in over 85 to 90% of cases. So when we look at the literature, templating on conventional radiographs had an accuracy rate of about 50 to 60%. But with the advent of digital radiographs, this has improved up to about 70 to 90%. There are certain digital apps which are nowadays used, like software like the Medicaid, that further improves the accuracy of templating. These are certain digital apps which can be used. There are studies which report their accuracy about 90%. This is another one. This is another study which from Egypt, which shows that the overall accuracy of templating the stem and implant size is about 81%. This percentage increased to 94% when considering sizes plus minus one as in our study. So our study actually matched almost all international studies. So we conclude that the preoperative radiographic templating of stem and a stabular cup size perfectly matched with intraoperative implants used in total hip arthroplasty in majority of our cases. We recommend operative templating, a mandatory step of preoperative planning in all patients undergoing total hip arthroplasty. And this exercise is very interesting for the residents. Initially, it was very difficult to convince them to do this, but once they started doing it, they found this exercise very interesting. And nowadays, our fellows and our residents routinely do this templating for arthroplasty patients, both our knee and hip arthroplasty patients. And this is how they actually do the templating. And on this size, already as non-cemented total hip was done. And this was in this case, you can see that they have put the cup in proper place, and they have also calculated the sizes. You can see that the cup size have been 0.5 centimeter, and the stem has been also been calculated. These are other examples of here. You can see that there is some protrusion. So we need to put this cup a bit. We can put bone graft and just build this so that our cup position is actually not crossing the cochlear line. Here you can see the size, the offset, the size of the stem, and the size of the cup has been calculated by preoperative templating. A problem arises when there is a gross deformity on the side you're operating. And then what we do, we actually template on the normal side and then transform that into the disease side. Here you can see that this is a grossly deformed, a previous girdle stone has been done, and we have to template for this. For this purpose, we do templating on the other side and then just replicate it on the disease side. So here you can see that the cup size has been calculated to be 52 millimeter and the femoral stem about 12. Now, what are the limitations of our study? This is a very small sample size. Only one aspect we have considered. We did not consider the limb length discrepancy. We did not consider about the cup positioning, but only the sizes of the implant were considered in the study. And there was no binding of the surgeon on the resident. Actually, this was not a blinded study. So this is another limitation of the study. So we are collecting data, we're continuously collecting, and we will inshallah do further studies, and we will publish our articles. We have sent another article on templating of the total knee arthroplasty to Pakistan Orthopedic Association Journal. Inshallah, that will also be published in the near future. Thank you very much, sir.
Thank you. Thank you very much. Saad, can you listen to me?
Yes, sir, I can hear you.
Yeah. So it's an excellent presentation by Dr. Saad. Thank you very much, Saad. It was very informative and conducive, and particularly for the young orthopedic surgeons and the residents. It was a quality product, and it's a good publication in the JPY. And we hope that inshallah we'll keep on having such quality articles and manuscripts for the future journals. Professor Bakar Saab is also on the panel now. I would request, if there is any question and answer, let the question and answers come, and then we'll request Professor Bakar Saab to give their expert opinion and the advices and the suggestions regarding the article and the questions and answers. Any question, please?
So there is raise of hand by Dr. Mohammed Shafiq. So if you allow me, sir, I can ask him to
please,
join.
Please, please.
Dr. Shafiq, can you hear me? You can speak now, please.
Hello.
Dr. Shafiq, can you hear us? Yes. Please ask your question, sir.
First of all, it is really a very good attempt, and I am very thankful to the chief editor, Ziaullah Bajwa Sahib, that he arranged such a good meeting for the first time. Also, it was also very good presentation by Dr. Israr, very expert, very knowledgeable, and also thankful to Abu Bakar Sahib कि इस रमजान में उसने टाइम निकाला and he is here with us. Actually, कुछ क्वेश्चन भी है, साथ में कुछ सजेशन भी हैं. क्वेश्चन ये है कि इसरार साहब आपने कहा कि sample size was short. You listen me?
Yes, can you repeat, Shafiq?
आपने अपनी आर्टिकल में कहा कि the sample size was short.
It
is nowadays very easy to calculate the sample size before starting the procedure or article or research. There is a calculator, sample calculator, and that is available on net. So you can easily calculate the sample size before starting the research. So why you people don't do that in your study? Pehla question to ye.
Okay.
Second question is that pathological fracture, there is indication of total hip replacement. So what was the reason of not doing this templating in pathological fractures? So okay. I have these two questions.
Shafiq, ये size sample की जो आप बात कर रहे हैं ना वो ठीक है, calculate आप कर सकते हैं, लेकिन when we compare our study with international data, there are studies. The people who studied more than 300, more than 600 cases. So this was basically an initial attempt from our side. There is no such study done in Pakistan. So this was initial study. We were excited to share our experience with only 60 cases. As I told you, our data is accumulating, and maybe in future we will present our large data size. It is insufficient to draw any major conclusions. Regarding your second question, why didn't we include pathological fractures? We have done templating for pathological fractures, but the actual implants used in those particular cases were not.
Hello.
I think there might be an connection error.
Hello, Assalamu alaikum.
Yes, sir, we can hear you. Assalamu alaikum, sir.
Thank you.
Please.
Thank you. Can I speak?
Yes, sir, please.
Thank you very much. First of all, I congratulate Dr. Ziaullah Bajwa Sahab, who has organized this webinar and has set an excellent tradition, which was not prevailing in the past, and the new traditions which was expected from the experience and the vision of Dr. Ziaullah Bajwa Sahab, who is the chief editor of the journal. And we really appreciate this effort, and we hope that this the same activity will continue in the future. And the presentation by Dr. Israr, who is also our honorable treasurer and office bearer, very important office bearer of the association. The first webinar he is addressing, I congratulate also Dr. Israr on this first presentation, and very excellent presentation and timely presentations, because it is the basic information and basic concept of the arthroplasty for the young orthopedic surgeons. Regarding the presentation, I want to add some practical tips which we have learned with our experience. We just want to share our department experience regarding the position of the stabler cup. Okay. The anterior and the posterior edge, which practically setting of the anterior and the posterior edge of the stabler cup. What practical tip we use? We just dip the few of anterior edge of the sternum. We keep that below the edge of the sternum to avoid. Otherwise, if there is a minimal protrusion of the anterior lip of a sternum of the cup from the anterior lip of a sternum, there is a great problem of impingement of the iliopsoas ligament, and that can become painful while walking. And sometimes you have to revise the stabler cup just for a few millimeter protrusion of the stabler from the anterior lip. So the anterior lip of the cup should be few millimeter deep to the anterior lip of the stabler, and should be protruded few millimeter from the posterior wall of the stabler. One thing. And secondly, regarding the size of the femoral component, that is, we just tradition is just pulling off the when we finally ream the final size of the reamer, we just check it practically by pulling the femoral component out towards the surgeon side, and we are satisfied that it is snugly fit, so it is the final size. But sometimes if you do the rotational movement, still the rotational movement is there. That indicates that this size is not optimum. So the pulling and the rotation both should be stable. Then that will be the final size of the femoral component. These were the few points I want to add. Otherwise, it was excellent presentation, and I again congratulate the organizer and the presenter of the this presentation. Thank you so much.
Thank you very much, Mr. Tassim, the president of Pakistan Orthopedic Association, for joining and giving valuable comments. I think you were talking about the uncemented femoral stem in the particular talk, but the presentation was about the cemented one, the templating sizing of the cemented one. Anyway, it was very valuable comment and the addition to that. And any other question, please? Any other word?
Actually, yes, Dr. Professor Peer Abdul Latif Saab from Hyderabad wants to ask question. I request him to please speak.
Assalamu alaikum, everybody. My dear teachers, seniors. Dr. Israr, a very good presentation about this templating. Yes, we agreed when we were exam FCPS, always preparing from Booster. We always used to ask the question about templating and internal fixation. Yes, in Elizabeth we use templating for deformity correction. It is very necessary. So I congratulate you to see this address this templating in arthroplasty. It is very necessary. I would like to ask you about what about the 3D printing and templating for this arthroplasty, and what about the exact cause of your error in getting size of shortening in acetabulum and stem. What was the basic cause of error in templating? Yes, sir.
थैंक यू पीर साहब, थैंक यू वेरी मच। सर ये जो आप कह रहे हैं कि साइज में क्या जो एरर किस तरह आ रहा है, तो ये टेम्पलेटिंग कैन नॉट बी 100% परफेक्ट। इफ यू गो टू द लिटरेचर, it's almost in a range of about 80 to 90% with one plus minus one. Probably initially there may be the templating quality may not be good as the template done by our residents and sometimes by our trainees. So there is always some error. It's not 100%. Regarding the 3D templating, it is done for complex hip surgeries, and we don't do routinely for primary or complex primary hips or knees, but 3D this has great role in when you are doing tumor surgery and when you're reconstructing some very complex hip surgeries.
Okay, thank you, sir. Thank you.
Thank you very much, Dr. Isra. Any other colleague who wants to ask any question, please?
Yes, any other question from the participant? If yes, let us know, or we go to have an
I
expert
welcome
opinion.
Professor Tashfin. I welcome Professor Tashfin also. He is one of the accomplished associate editors. I will request him if he wants to give any comments on it, please. Unmute, please. Please unmute कीजिएगा. Yeah.
जी, अस्सलाम वालेकुम.
जी.
Thank you very much, and I concur with Professor Tehseen that this is a great continuation of the efforts that were to promote literary activities, promote the popularity of our journal, as well as promoting a culture of discussing articles and discussing research. I've been part of the editorial board for many years now, even before this current one, and I thank the POA and the editorial board for keeping me on this. This is something that I really enjoy, and I'm glad to see the progress. Even in the previous tenure, a lot of progress was done, and I'm quite sure that in this current leadership, also further progress will be made. Regarding the article, I think it was a very, very, very good article. One of the reasons is that templating is often missed in busy centers, especially. And your article is pointing us to the fact that it is very useful to help us get the right implants. And these days, especially, there's a shortage of implants. Especially things import is becoming very difficult, and a lot of centers, a lot of vendors have problems in providing all the range. Ideally, all implants of all sizes should be available at the time of surgery, but if they are not, then this templating will ensure that at least you have the most probable sizes available in your stock. So I congratulate the authors for a very nice study.
Thank you. Thank you very much for valuable comments. And we'll be looking forward to further help us regarding improvement of the journal for such learned associate editors and the colleagues from POA all over Pakistan. And we will welcome any suggestion regarding this POA and JPOA. And you have the email, and you will always be welcomed, and you will be always responded regarding your suggestions of developing, adding, and something, and whatever you feel like is good for GPA, you will always be welcomed, and we'll accommodate you as much as we can do for that. And we are doing the same, and according to the HEC and the requirements to continue this, the recognition and further improving the value and standard and of the JPA, and we need help from all of you, including each and individual member of POA. This is our journal, this is your journal. We all collectively have to work on it. And regardless of anything else, you are most important to us because you're a member of POA, and you will be given a due regard and a due respect and accommodated according to your suggestions and whatever you feel like is good for JPOA. I'm extremely thankful for the honorable members and the senior ones who are participating and participated here. If there is nobody else for a question, Professor
There
Abu
are the
Bakr.
questions. There are the questions.
Yeah, please,
Dr.
please,
Badal from Balochistan.
Yeah.
The question is, sir, how to negate major cavatorial defects in templating? Dr. Sir, can you hear us? So the question is, sir, how to negate major cavatory defects in templating?
In templating, you actually put your cup in proper site. Like you said that you just you keep your landmarks in mind. For example, the teardrop line and then the collar line. Your cup should not cross the collar line. Your cup lower edge should be at the teardrop line. So you put your cup at that side and you see that is there any defect, cavitated defect. If there are cavitated defects, then you have to fill it with bone graft. Sometimes you use these augments like TM augments. Sometimes you, when the defect is very much, then you can use cages as well. You can use the catch cup construct. It depends on the defect, and you can put your cup in your proper size. For example, it has sunk in. You need to build your cup and put it at the proper anatomical size. After that, if there are defects, then there are various ways of filling those defects operatively. Professor Abu Bakr, I think, can respond, sir.
There is another raised hand.
Yeah.
Professor Masood Umar wants to say or ask a question.
Please, welcome.
I think very nice presentation, Dr. Israr. Congratulations. This was work we used to do as residents under Professor Umar Saab. On every case, he would make sure that I have made templates, I have made sizing for all cases. But then the idea, as we became senior, gradually faded out. And then from my personal experience, as Dr. Tashfeen was also saying, when I went to Mayo Clinic, USA, for oncology training there, they were also doing side-by-side arthroplasty in other ORs. I used to visit them, and it was mandatory for residents to template. So just to highlight your point that such a busy center, they do maybe more than 20 knees or hips together in one day, in one list of all the operating rooms, and everybody would be templated before he or she, the patient, comes to the operating room. So I think your article points to a very pertinent pre-operative evaluation that becomes especially important when there are dysplastic hips. So dysplastic hips is a very special category, which is where templating is mandatory, where you would always require special implants, very small size femur, narrow femur, and obviously, as you said, dysplastic vertical cups where you will have to use augments that would define how much and how many augments would you need. I have done some studies on Singaporean population in my fellowship there on the morphometry of normal hips. Actually, my project was to gather normal pelvis AP X-ray and then measure the morphometry, and I have published that. And it was found that about more than 20% of the hips are dysplastic, and there were definite objective criteria. We haven't been able to repeat that study, but
Hello.
I think the mic has been muted. Professor Umar, if you still want to add, or we can proceed.
During surgery. Thank you very much for this opportunity. Learning for me also. Thank you. Thank you, Assalamualaikum.
Thank you very much, Professor Umar, for very valuable comments and addition to the knowledge of everyone. Anybody else? Any question, please?
No, sir, I don't found
No, sir.
any question
No,
from
it's,
now
it's
onward.
getting very difficult for me or even Professor Abu Bakr himself to stop himself from giving his valuable comments, and he's bubbling out with his knowledge and expert opinions. Professor Abu Bakr, no introduction required. Every person, everybody in the country knows him. He's been the accomplished and an honorable past president of Pakistan Orthopedic Association. We had requested him to be the expert on the article. So we are thankful to him. He accepted and got some time from his busy schedule. I hand over my mic to Professor Abu Bakr to give his valuable comments and his opinions and certain questions which he has already noticed and noted during the discussion. Please, Professor Abu Bakr Siddiq.
Assalamu alaikum. Can you hear me?
Yes.
Yes.
ये बहुत अच्छा लगा आज साहब को सबसे पहले देख के और इसरार को, आपको, तहसीन को, ताशफीन को, उमर को और बाकी लोगों को कि इतना अच्छा आपने ये वेबिनार इसके ऊपर अरेंज किया. Congratulations to Professor Bajwa for organizing all that and the others participating. इसरार का आर्टिकल जो था, आई थिंक इसका रिसर्च क्वेश्चन जो है वो अभी भी उसी तरह से वैलिड है जो आज से 30-35 साल पहले वैलिड था. तब भी हम टेम्पलेट करते थे, अभी भी हम टेम्पलेट करते हैं. और जो कर्लर लाइन है और जो आपका टीयर ड्रॉप है और पर ऑपरेटिवली जब आप कॉटलेट फॉसा को देखते हैं, ट्रांसवर्स लिगामेंट को देखते हैं, तो दैट इज योर बेसिक सेंटर कंसिडरेशन जिसको आप कहते हैं कि आप अगर इन तीनों चीजों को मिस कर देते हैं तो यू मे वंडर फॉर योर स्टेबलर कंपोनेंट. आपको कोई पता नहीं लगता कि आपका स्टेबलर कंपोनेंट किधर जाएगा, क्या करेगा या क्या होगा. दिस इज अ बेसिक लर्निंग और इसको बेसिक प्रैक्टिस करनी चाहिए और इसको कभी भी नहीं छोड़ना चाहिए, इवन एट द रेजिडेंट लेवल एंड इवन एट द वेरी मैच्योर लेवल. जब आप पता लगता है 500 कर चुके हैं टोटल हिप्स, फिर भी आपको इसके थ्रू गुजरना होगा, तभी आपकी एक्यूरेसी जो है वो बेहतर होती है. आई थिंक इट्स अ गुड एक्सरसाइज इन अवर पार्ट ऑफ द वर्ल्ड. रिजल्ट्स की जो वेरिएबिलिटी है उसके ऊपर बात हो रही थी. इफ इट इज 70% to 80% मैचिंग योर पर ऑपरेटिव फाइंडिंग्स, तो जो वेरिएबिलिटी है वो वेरिएबिलिटी आपको जब पता चलता है कि देयर आर आपकी एवरी पेशेंट एक्सेप्ट फॉर द फ्रैक्चर पेशेंट देयर इज ऑस्टियोफाइट्स जिनके डिजनरेटिव होती हैं, दे do have a little bit of a misguiding to your reaming and to maybe your placements of the cup and maybe your 45 degrees and the antiversions both. So उसमें आपकी जो वेरिएशंस जो होती हैं पर ऑपरेटिवली आपको एडजस्टेबिलिटी, ये वही वेरिएशन जो आपके रिजल्ट्स के बाद रिफ्लेक्ट करती हैं कि प्री ऑपरेटिवली इट वाज a 47 and पर ऑपरेटिवली इट वाज a 49 cup. There was any void to be filled in by any bone graft on the medially or posteriorly or somewhere ever you want. So that is, I think, वो बात दुरुस्त है. मेरा जो प्रैक्टिकल एक्सपीरियंस इसमें है कि आप एपी व्यू में उसमें इंटरनल रोटेशन में जब टेम्पलेटिंग कर लेते हैं तो नॉर्मल लेग इज अवेलेबल टू आप साइमल्टेनियसली उसको भी करें तो दैट गिव्स यू मे बी अ मोर एक्यूरेसी और मे बी अ लिटिल बिट ऑफ जो आपकी इफेक्टेड साइड की जो टेम्पलेटिंग है उसको देखते हुए. ट्रू एपी व्यू जो है कई दफा उसमें भी आपको पता चलता है कि मे बी 5-7 डिग्री पेल्विक टिल्ट है या कुछ तरफ है, मे बी आफ्टर सम स्पाइनल प्रॉब्लम्स, उसका ट्रू एपी व्यू भी पेल्विस का आपको जो है समटाइम्स नहीं मिलता. उसमें भी ये एडजस्टेबिलिटी जो है ये आपको फिर वो काम देती है ताकि आप दोनों को आपस में मैच करें. बेसिकली इट्स रिकंस्ट्रक्शन ऑफ दैट पर्टिकुलर हिप which is damaged and this should be reconstructed to its actuality. और एक्चुअलिटी के लिए आपको जैसे इसरार कह रहा था वही पॉइंट्स अवेलेबल हैं आपको ऑन द एपी व्यू. आपको टीयर ड्रॉप है, आपका कॉर्नर लाइन है, आपका स्टेबलर रिम है जो आपको नजर आ रहा है. इवन यू कैन मेजर योर ऑस्टियोफाइट्स इफ यू कैन टेम्पलेट इट ऑन द अदर साइड एज वेल कि हमारा प्री ऑपरेटिवली आपके कितनी. ऑल दोस 3D reconstructions में और ये digital templating है, they have done that और applications available हैं. मेरा ख्याल है हमें उसकी तरफ भी simultaneously जाना चाहिए. ये नहीं कि हम उसको totally negate करके इसी के ऊपर बैठे रहें. लेकिन ये जो basic templating है, this should stay always there. आप इसके ऊपर डिजिटल कर लें, इसके ऊपर वो टेम्पलेटिंग कर लें, 3D के साथ कर लें और इसके साथ कंप्यूटराइज्ड वो कर लें और व्हाट्सएवर यू वांट टू. लेकिन बेसिक जो है, और मैं तो कहता हूँ तो ड्राइंग करने के बाद यही आपके एक्सरे जो हैं दे शुड बी इन द ओटी, जो आपके सामने हर वक्त लगे रहें. मैं जो प्रैक्टिकल टिप में इसमें आपको थोड़ा सा देना चाहता हूँ, पर ऑपरेटिवली अगर आप उसको एपी व्यू में आप इमेज इंटेंसिफायर में आप देख लेते हैं, दैट इज अगेन योर कंफर्मेशन ऑफ 45 डिग्रीज ऑफ योर. जो तहसीन जो कह रहे थे कि जब आप पता करता है कि आपका ऑफसेट ठीक है, लूसनिंग तो नहीं है, कुछ नहीं है, हम उसको टेलीस्कोप करते हैं. तो टेलीस्कोप इन वेरियस रोटेशनल पोजीशन में भी कर लेना चाहिए, उसमें अर्ज कोई नहीं है. दैट मे प्रिवेंट यू. तहसीन एक बात क्या कर रहे थे कि इंटीरियर साइड ऑफ द कप जो है, आप द स्टेबुलर है और आपका कप है, उसको आप उसको प्राउड ना करें. प्राउड का मतलब है कि आपके इलियोपसोआस का टेंडन उसके ऊपर रब ना करें. मोस्ट ऑफ द टाइम आपने देखा है कि हम इन केसेस के ऊपर कई दफा उसकी रिसेक्शन तो कर देते हैं इलियोपसोआस के टेंडन की, उसके वो रिसीड हो जाता है. तो वो एक तो वो रिसीड होने से उसकी वो भी थोड़ी सी लेंथ उसको गेन हो जाती है, इसलिए उसके रबिंग के चांसेस कम होते हैं. दूसरा ये है कि आपको उस वक्त आपको देख लेना चाहिए कि आपका ऑस्टियोफाइट अपना कितना है स्टैबुलम का, और आप उससे 1-2 मिलीमीटर नीचे रख लो, इसके साथ फ्लश भी रख लो, then it's all right. It doesn't give you any problem. I think it was a wonderful exercise in this article, or you continue with this, and अगर आप comparative studies में enter हो जाते हो इसके बाद, ठीक है, this X-rays, digital X-rays templating into a system-based computerized templating, the 3D templating के साथ, so that may be again a very good study to publish in the future. Thank you very much, everybody.
Thank you, Bakar Sahab. Thank you, Israr Ahmed, Professor Tashfeen, Professor Tehseen Riaz, the President, and all the participants who really participated in this activity. I'm really thankful to all of you for joining us. And inshallah, we hope the next time again, we'll see you with another article and with another presenter and an expert on the subject. So thank you, all of you, and thank you particularly Saad, Mr. Saad. He's been very kind,
Yes,
and he's working effortlessly all the time, 24 hours a day. Whenever required, he's there to help and and assist in each and every aspect of this activity. Thank you very much, Mr.
Thank you,
Saad,
sir.
and all of you. We'll see you next time with a new article and a new presenter. Mrs. Israr wanted to tell something, please.
No, sir, I just want to acknowledge and thank you.
Thank you, Ji. Thank you very much. Thank you, all of you. God bless you.
Thank you very
Allah
much,
Hafiz.
Ji. Thank you so
Allah
much.
Hafiz.
Hafiz.
Thank you.
Thank you
Hafiz.
very much. Thank you very much.
Thank you, Israr
Very
Sahab.
good exercise.
Zabardast.